Okay. Sorry, okay. Hi, everyone. Long time. I'm excited to share this case. So this was an older gentleman presenting with symptoms suggestive of acute pancreatitis. And I'm going to scroll through his first CT here. This is a contrast-enhanced portal venous phase CT. As you can see, there is some fatty liver here. And indeed, he has a picture suggestive of acute pancreatitis with stranding of peripancreatic fat here. The head seems to be involved the most, and there is a hypoattenuating fluid collection in the region of the head. So he gets treated as acute pancreatitis. Incidentally, he happens to have multiple other incidental findings, such as renal cysts here. Let's ignore that for the time being. He also has gallstones, and so there is a presumptive evidence or presumption made that the pancreatitis may be related to a past stone. He gets treated. He feels all right.
I have a question, Anu.
Yes.
And like towards the top of the pancreas, as you scroll down, yeah, it almost looks like the fluid is like walling off around the top of it, which to me suggests like it's more cranially, not there, but there, but also cranially. Go up there.
Right here, right
Yeah,
here.
it seems like it's almost like getting walled off. So to me, if it is pancreatitis, it's more subacute, or like it was like a week ago or 2 weeks ago or something like that. You know what I mean?
Yes, you're absolutely right. Because this imaging was not performed at the time of presentation. He had an ultrasound, and there was chemistry suggestive of acute pancreatitis. So when his symptoms worsened, that's when he got the CT.
Okay,
So
got
you're absolutely right. Yeah. And if we want to see that finding, we can even look at this finding on in the coronal plane, and this is sort of the collection that you're talking about. So he goes about his way. He feels, he is not 100% okay, but he is getting better symptomatically. And then he subsequently, a couple months later, is again symptomatic. So gets a repeat CT. This is his CT exactly 5 months later. And now you can see that suprapancreatic collection has resolved. The body tail of the pancreas looks pretty okay. He continues to have this collection in the pancreatic head, and chemistries are abnormal. So it's assumed that he has a recurrent bout of pancreatitis, and he gets treated. He is lost to follow up, and then he
Can you scroll
presents.
through that collection in the pancreatic head again?
Is
Yes.
that collection looks
It looks
like
funny.
very tubular? Like, is that main duct IPMN?
Like two separate compartments. Like, and then there's like a
Yes.
rim enhancement component to the anterior one, and then a tubular thing posteriorly.
Okay, excellent. All excellent observations, because you are totally headed in the right direction. I just wanted to start off with, showing the entire case first, but that's a good thought. And in fact, at this point, we do need to pause and think, this has not resolved. It's been a few months. It does seem like there may be some wall to it. The main duct is not dilated here, but again, yes, the configuration of
And
this.
then, sorry, along the cranial again, next to the duodenum, but there's a projection, but maybe scroll down a little bit there. Up, it's like a little pyramidal thing, but that just might be a variant. Yeah, like I think it might just be a variant of the pancreas.
Yes, you know how you get sometimes that unicorn horn-like projections.
Yep.
Yeah, so that
right
is
there.
Yeah, here, right here.
And then just south of that, caudally, right there.
Yeah, I think it's just part of the pancreas.
Okay. Sometimes it's really hard to see a pancreatic mass. Interestingly, there's no ductal dilatation.
There is no ductal dilatation. This is in the head of the
body,
pancreas. Yeah, almost going to. Yeah, so there is no ductal dilatation. Yes. And, that's why perhaps this was assumed to be some residual pseudocyst, or I know we have different terminologies. For now, we'll call it a collection in the head of the pancreas.
If it is a main duct IPMN, it could just be of the uncinate duct, not of the main duct, because you can see the main duct above it, right there. Yeah,
here. The main duct seems like it's a little compressed, but it's not obstructed. Or, yeah, it's not dilated. And exactly, if this is an IPMN from the main duct, it doesn't arise from it. So all great thoughts. Subsequently, he gets lost to follow up, and then he comes back. At that time, he has an MRI. I'm going to not show you a couple intervening MRs. I'm just going to show you the most recent MR. So this is his most recent MRCP, and that quote unquote collection has increased. You can now see that the main duct is markedly dilated. Here is a T2 weighted sequence again by this stage, and in between there is a gap of 4 years. I'm fast forwarding to 4 years later and showing you this imaging, most recent imaging. Main duct is dilated. That lesion is now much larger. And at this point, there is concern raised that this may be either an IPMN or malignancy developing within an IPMN, given all these additional findings. This gets resected, and indeed, I'm just going to show you one CT as well. No contrast here, but this is the CT that corresponds to the findings on MR that I just showed you. So this gets resected, and it comes back as an invasive, well-differentiated mucinous adenocarcinoma, the colloid subtype, arising from an IPMN. And the subtype of the IPMN is an intestinal subtype of IPMN. So, just goes to show that sometimes, just quickly going back to the presenting CT, of course, he did have some gallstones at that point, but he's an older gentleman. So a word of caution and a dictum sort of I follow now is that in an older person, when they present with pancreatitis for the first time, no history of alcohol, yes, gallstones could be, but also keep in mind that there may be a malignancy lurking that can predispose to acute pancreatitis in this age group. And then he did have multiple imaging studies in between. And each time we kept thinking that this is a sequela of acute pancreatitis. Even on the last one, where the lesion had increased in size, the main duct was now dilated. We there was a thought process that this may be recurrent bouts of pancreatitis. But a couple features that stand out are that hypoattenuating lesion kept increasing in size, no calcifications. If patients have recurrent pancreatitis, there should be some calcification. That's the process of healing. Calcification either in the duct or within the pancreas. But here you have an expansile process, no calcifications, and then gradual enlargement of the main duct as well. So a couple pointers that would alert you to there being a malignancy brewing in that region. And then a quick blurb on the types of malignancies developing within IPMNs. So I pulled up this interesting article from 2023. Typically, IPMNs tend to have 4 subtypes of histology.
Can you zoom in,
within
please?
them. Sure. Is this better?
Yes, thank you.
Okay, excellent. So the 4 subtypes of the histological subtypes of IPMNs include intestinal, pancreatic, biliary, gastric, and oncocytic. And it was, and there is a relationship of colloid or a mucinous non-cystic adenocarcinoma with the intestinal subtype of IPMN, and that's what our patient had. And then the other type of malignancy that can develop within IPMNs includes the tubular or the ductal adenocarcinoma, which is more commonly associated with the pancreatic or biliary epithelium within the IPMNs. So I can stop here. Any questions?
So my thought is, like, can you differentiate the two? I guess the intestinal one is more like what you're presenting, more cystic look, and then the other is more solid look.
Yes, but I think that's, the final differentiation is histologic. I'm not sure if we can distinguish the different types of IPMN by imaging. I mean, one differentiation, yes, is the more cystic in intestinal, and but I think that's more when the malignancy develops within them. The colloid ones are more cystic, whereas the ductal adenocarcinoma subtype tend to have more um, ductal obstruction. Earlier, they present with earlier ductal obstruction and enhancing components. So we can.
Yeah, I agree with you, Anu. I think it's really interesting as a pathologic diagnosis, but I think in general, we are not good at, in imaging wise, in distinguishing between them. But just know that there are these multiple subtypes. The intestinal one is the one that leads to that mucinous type, and that can be sometimes more engorged, but not always. I had one of those cases, and it actually had mucin spreading around the pancreas, and it came back mucinous and colloid, and so that was, it made sense, but it's not always, sometimes it can just be a smaller lesion. We can't tell the difference. And I think your case in general is a really good reminder that, like, whenever we have pancreatitis, we should always look to see is there an underlying mass, whether it be like a true ductal adenocarcinoma or an IPMN, because I've seen that more and more now where, like, we're just like, oh, it's pancreatitis. And you miss that, oh, it was caused by this actual underlying mass. So the follow-up is really key.
Indeed. Thank you.
Yashant is actually saying something, let's see. If patients who have a first episode of pancreatitis who are over 40 and no identifiable cause, they should get a contrast enhanced CT to exclude a possible neoplasm. And that's from a paper that he just pulled up. So yeah, thank you. And Yashant, when you say contrast enhanced CT, I think sometimes in the moment where there's still acute pancreatitis, it's still kind of cloudy and hard to definitely tell what is happening. And so at least they should get like a short-term follow-up.
Yeah, I agree. Short-term follow-up, because even when we actually talk about guidelines, when and how to image pancreatitis, they say wait for 48 to 72 hours after the first episode of pancreatitis, because in that time the findings will evolve, but nobody waits for that long. We typically do whenever the patient presents, but that's when, like, you will be able to tell even the difference between, is it the interstitial subtype or is it the necrotizing subtype. And another thing is, like, pancreatitis usually is a generalized process. Like the entire pancreas more or less will be involved. So especially when we see small adenocarcinomas in the body or in the tail, and if there is only focal pancreatitis, like just tail is involved, then also think in terms of that there could be some malignancy hiding.
Yes, actually, they just presented this at SAR where tail pancreatitis, like when it's focal like that, has a much higher rate of being due to a malignancy, an occult malignancy. So now I'm really cautious when there's just tail pancreatitis.
All great points. And then also, if you keep repeatedly imaging and we don't see calcification, that's another clue that there may be a malignancy brewing there. Like here, the collections may not necessarily be collections related to pancreatitis, but it could be like a mucinous subtype of malignancy.
Awesome. Okay, so this patient presented with abdominal pain.
Intussusception with a lead point mass.
Yes, excellent. So we've got a gorgeous intussusception here. It's pulling the mesentery and the vessels in. It's a small bowel intussusception. So it's going all the way here. And then we have this lobulated mass here. So what do you think this mass could be?
Statistically, it should still be adenocarcinoma.
Yeah, I was actually thinking like maybe this is a huge like tubulovillous adenoma, the way that it looks kind of like polypoid and cauliflowery and, but obviously when it's this big, it might have adenocarcinoma in it. It looks too lobulated to me to be like a GIST tumor. It's obviously not a lipoma. So neuroendocrine is usually not big like this. Anyway, this ended up getting resected and it came back leiomyosarcoma. So I just want to show you, it's a small bowel leiomyosarcoma. Can you guys see my screen here? My Radiopedia screen?
Yes.
Yeah. So it's the case that they have of a leiomyosarcoma of the small intestine actually looks just like my case. Oops, I'm trying to like move everything around now. Hold on. Okay. So So here is their case. And it's this big, large, lobulated enhancing mass that's intraluminal. And it looks just like my case. So a couple of the points that they make in this Radiopedia article is that leiomyosarcomas are actually 10% of small bowel malignancies. So they're not as rare as we think, although overall small bowel malignancies are rare. So this is like going to be a rare subtype of small bowel malignancies. And they tend to be large. They can show extraluminal growth. Bowel obstruction is rare. So that's why in my case, for example, even though it was very large, it wasn't causing a bowel obstruction, but because it's pedunculated, it caused that intussusception. It can cause abdominal pain and melena, and it's usually hematogenous seeding into the peritoneal cavity. So I just thought it was a good companion to that case. So this was a leiomyosarcoma, no mets at this time. Also, these like to met to the chest, so always get a chest CT as well.
So incidental finding on this CT. So I'm showing you the scanogram. And if you want to shout out, what do you see?
Well, lots of clips in the chest, but then I see these two round dense things like on the overlying the pubic symphyses. The pubic
That you can ignore. That's actually, I think, from the dress material.
Oh, okay. What is that like also tubular thing overlying like the actual pubic symphysis?
Yes, exactly. So let me show you how it looks on CT.
It's like a condom catheter?
Yes.
Nice. Ever since you showed us that PureWick, by the way, I've seen it in so many patients. I feel like it's a really popular now urinary continence device.
Yeah.
Nice. Okay, so also not an eye test, but a really, really nice case. Anu was just saying I have a theme of intussusceptions today, which is true. Although this is the end of my theme. So, okay, so we've got this bowel loop coming in with all of this mesenteric fat. It's coming on over. And then we end up over here.
Why did you mention there's a between section?
I'm going to show you the coronal.
Lipoma or liposarcoma. I don't know. Is there soft tissue component? I'm not sure.
Yes, so this was exactly my thought. I thought this was like possibly a lipoma. I've had a big lipoma like this be a lead point. And I will just I think this is actually some weird part of the mesenteric fat. But what I will point out is actually there's like this air and fluid here that is ill-defined and it's not in bowel. So there's some perforated bowel here. You guys buy that?
Yeah.
Yeah. Anyway, they resected this, and this was a perforated Meckel's diverticulum. There was a Meckel's diverticulum that had intussuscepted, and then they think it perforated when it was intussuscepted, and so when they went to resect it all, this was all a perforated Meckel's diverticulum.
So patient had lipoma of Meckel's, or lipoma was just present just like that?
I think it was just an adjacent lipoma.
Okay.
Yeah, it was a crazy case. But I think the thing that is important to bring up here is that we think there's a bowel perforation because of this free fluid and air. I mean, it's such a long intussusception. We have occasionally been asked to reduce intussusceptions in older non-surgical patients, but when it's long like this, there's a lead point, and especially because there's a perforation, that's basically a surgical case.
So in adults, what technique do you use to reduce? Because the teaching was only pediatric patients we reduce, not adults, because usually there'll be a lead point, they're long, difficult to reduce.
We did it in one patient. We basically did an air contrast enema, but we had the surgeons there with us because like there's always that like the risk of perforation.
Yeah.
And so we said like we're not going to do it unless you guys are here, and so they were in the fluoro room with us, and we were actually able to reduce it.
Nice.
And in that case, there wasn't an actual mass or anything like that. It was from like a bad colitis, but it was so edematous that it caused this intussusception.
Okay, got you.
Okay, so this patient came in with abdominal pain.
Stomach lymphoma or some soft tissue mass, just what's that mass around the greater curve of stomach?
You tell me.
Let's see the coronal plane, please, to
Okay.
see if it is on the surface or arising from the stomach wall.
Zoom in.
Interesting. Here it looks like it's abutting the stomach.
Yeah, there's some process of budding the stomach. Okay, so you said lymphoma. I will say also, like there was this tangle of vessels going
Vessels,
into it,
yes.
right?
Mhm.
And then this was all thought to be maybe blood.
Mhm.
And so when first that people were looking at this, they're like, oh, maybe there's an AVM coming off of the stomach and bleeding. Because like this is all going in different directions, right? So a lot of this was just blood. So I'll tell you a bunch of this was blood. Now the question is, do you think this is an AVM? Have you ever seen an AVM like this? Hanging off the stomach?
Or could
I
it
have
be?
never seen that.
Yeah.
Or is it more mesenteric and drawing blood from, like, it can be mesenteric, like how we have not extra mural, but how we have angiodysplasias and but they're more, I agree, mural and more submucosal.
Exactly. Like if this tangle had been in the wall, I might be like, oh, that could be an AVM or angiodysplasia, but it seemed like it was like outside the stomach. So anyway, you know how they say better than a good radiologist is an old exam. This was the old exam from 5 years prior. And look what's there.
Nice. Yeah.
So there was a little gist here,
Mhm.
a little exophytic gist, and it had grown and then ruptured in the next exam. So then we did an EUS biopsy of this, like, you know, after the bleeding kind of, oh, so IR went and actually embolized the vessels feeding that, the bleeding thing. And then the gastroenterologist went and did an EUS biopsy of this area, and it came back gist. So yeah, just a cool, weird looking ruptured bleeding gist.
I was just bleed
Sorry, what were we
because
saying?
I was thinking less in terms of bleed. I mean, yes, that's a possibility for sure, because this was still kind of well defined. There was no stranding around this process.
There was no stranding, but it was actually all like bleeding, and in IR it was actively bleeding.
Okay, okay.
Yeah, so it was a ruptured gist. But I will say, you are right that gist can grow in this kind of multilobulated fashion. And this would have been a good look for like a post-Gleevec gist, for example.
I don't know.
Yes.
Like a
yes.
more devascularized kind of thing. I'll share my screen again. Hold on one sec. Yeah, so I've seen cases of GIST that are like post-Gleevec where it kind of devascularizes and looks like this kind of blobby multilobulated thing. But this patient hadn't been treated for anything, and it was actively extravasating. So, yeah.
So this is companion to the case that Shekhar just showed for the first case for intussusception of small bowel, although not as impressive. It's not a very well-defined lead point, but this was also small bowel leiomyosarcoma.
Nice. It looks very similar.
Yeah.
So maybe we can bring it up now if we see like a sort of mass that's not causing an obstruction, but causing an intussusception. So we know it's like more pedunculated kind of and lobulated like this.
Yeah.
Cool. Okay, let me know what you guys think.
Cholangitis. Portal biliopathy.
Looking for
What
where is
is-
the site of what is obstructing the CBD.
Good. So CBD, there's some dilation.
Intraocular.
There's also splenomegaly and probable chronic liver disease.
Mhm.
CBD is dilated, and then it kind of comes down here.
Portal biliopathy?
Yeah, good. So this is portal biliopathy. So basically, this is cavernous transformation of the portal vein.
Yes.
You can see that there's, eccentric, basically the patient had cirrhosis, portal hypertension, thrombosed off their portal vein, ended up with all of these varices, and then those varices caused the portal biliopathy, which is causing this biliary obstruction. The mechanism is thought to be that there's the dilated cavernous transformation is both within the wall and around the wall of the bile duct, and it causes like an ischemia as well as kind of just mass effect that causes this obstruction. It's also called the pseudo-cholangiocarcinoma sign. So that biliary obstruction, no real cholangiocarcinoma would let a bile duct just go through it. The other cool thing in this case is that it's really prolific around the gallbladder. I'd never seen extensive varices like this, like surrounding the gallbladder, but you can see this also really doesn't look like a gallbladder adenocarcinoma. It really just looks more like that portal biliopathy. And we did end up getting an MR, and we could see that there was no, it was all just flow voids and dilated vessels around both the bile duct and the gallbladder. And no real convincing mass here. And I wanted to show you this radiographic. So this is one of the cases from the cookie jar. And sometimes when it looks like a mass like this, we call it mass forming portal cavernoma. In this case, it was like that in the portal, but also around the gallbladder. And this is a nice description of how basically in the gallbladder wall, you get all these vessels that cause and all the vessels around it that cause that kind of narrowing and luminal, narrowing of the bile ducts that cause the biliary obstruction. And then this is an example. Let me try to zoom in. I can't really zoom in, but anyway, it can, oh yeah, maybe if I do this. Yeah, it can really mimic a mass. It can look like a lot of soft tissue enhancement. It can even look like evil gray of tumor. It doesn't always look like a lot of flow voids. And this is when we call it like a cavernoma, a mass forming cavernoma. So yeah, that was my case.
So on this note, once I was thinking to myself, how long does it take once the portal vein goes down for cavernous transformation to occur? Any thoughts?
It actually happens really fast because
Yes.
veins are already there. They're like a lot
Right.
of the periduodenal and
Dormant.
there's this whole plexus of periportal veins that are there. So as soon as the portal vein goes down, it starts filling into those veins. But
Yes.
for it to sort of get to this point where you have the biliary obstruction, the pseudo obstruction, I think that takes a little bit longer.
I agree completely. It was surprising to see that it can actually open up those dormant veins within days.
Yep. Yeah, it's amazing. And actually, it's interesting in this case, they actually put, they put a stent into the bile duct. And some of that proliferation, like the sort of vascular, around the common bile duct actually got alleviated. So I don't really know the mechanism there, but it seems like it shunted back into, some other vessels. The portal vein is still out, but somehow just alleviating that biliary obstruction caused some of the varices around the gallbladder to decrease. So.
Nice.
This is a patient who's postpartum, and they had this finding. They were still having some vaginal bleeding, and they had this finding. Their actual endometrial cavity looked okay.
I have a differential for this.
Yeah, go for it.
One of the newer things that they are now talking about is enhanced myometrial vascularity versus AVM, it's not endometrial, so
Oops.
it is not RPOC.
Exactly. So can you tell us more about this? I'm going to bring over my screen here, but he's talking about EMV, or enhanced myometrial vascularity. And this is a commonly seen thing postpartum. So something that, for example, in this case, it was brought up that this could be an AVM. And the main teaching point here is that AVMs are extremely rare, whereas enhanced myometrial vascularity is common. It's usually seen after a second or second trimester miscarriage, or in the postpartum setting with or without RPOCs. So basically the RPOCs would be in the endometrial cavity itself, and then the enhanced myometrial vascularity would be in the adjacent myometrium. It's a very common finding. It's something that we should not mistake for like placenta increta or for an AVM. I'll just pull up the right. So, Yashant, was there anything else that I've only recently learned about this. There was actually a radiographics article about this recently. So that's where I learned about it. But do you have any other teaching points?
So one thing is starting with RPOC, which is more like endometrial process. So cutoff for RPOC is 1 centimeter without vascularity. If something is hyperechoic and something as in like the endometrium is measuring 1 centimeter generalized or focal without vascularity, that should raise an alert that it is RPOC. The uterine AVMs and myometrial vascularity, they are obviously myometrium based, and as you rightly said, they are very uncommon. It comes in 2 flavors. One is congenital, that's much more rarer, versus iatrogenic, that is more common. So the patient should have a history of, say, dilatation and curettage, because that's where the trigger is for AVM to
For the
form.
AVMs, yeah.
Yeah. These are impossible to distinguish in the early period, so they have to wait. And this increased vascularity, if it is because of enhanced myometrial vascularity, it will go in, I think, 2 or 3 weeks after postpartum.
Yep,
So
exactly.
instead of being aggressive, they have to do a short-term follow-up.
Exactly. So the take home is AVMs are rare, occasionally congenital or traumatic, but generally very rare. EMV is thought to be much more common, and they usually spontaneously resolve. It says like after about 5 weeks. And it could be quicker with watchful waiting, blah, blah, blah. And then occasionally, if they do have the RPOCs, they can do a DNC, and there's no, that usually leads to the resolution of the EMV, and there's no increased risk of hemorrhage when you're doing a DNC. So they can still do a DNC even if you have the EMV, and then the EMV usually resolves. Awesome.
Yeah, ready. So companion to the mass-forming cholangiopathy. So we see this enhancing soft tissue mass. We see it is still lobulated, so a lot of these are vessels. But this mass particularly, and when I show you a T2, it's all hypo, like really, really dark. And when it comes to enhancement, so that's the hilum, and that's where the portal, the CBD gets really low caliber, and we see this enhancing mass-like thing. So that's where a lot of fibrosis happen, and it is mass-forming cholangiopathy.
Nice. Yeah, and you can see the bile duct going through it, which like a cholangio would never really let that happen, you know? But I remember in the past when I've seen this, like sometimes we're like, that's too much soft tissue. We should bring up lymphoma. But now I'm kind of seeing this more and more with the portal, like cavernous transformation.
Yes.
Sorry, what was the name of the entity again? Mass-forming cholangiopathy?
Yes.
Well, the general term is portal biliopathy, where we're getting the biliary obstruction from the cavernous transformation. And then there's this newish term from the cases from the cookie jar, like mass-forming cavernoma.
And in fact, one of the things they talk about, if there is portal biliopathy and there is a replacement of portal vein. So one of the specific things that, it is more likely to be because of portal vein obstruction is we see varices in the gallbladder wall. So gallbladder wall varices is a indirect sign that portal vein is gone.
Yep. Nelly, when you had stepped away, I had just shown a case of that where like there was a lot of proliferation around the gallbladder wall.
I caught the part of it, and I'm like, oh, you have a companion case.
Yeah. Yashant is the master of companion cases.
Yes, yes.
You guys are being too kind and generous.
Okay. So focus on the liver.
Sick patient in terms of infectious symptoms?
They have some vague right upper quadrant pain.
Is this ruptured gallbladder with abscess formation? I see those stones.
Yes.
Or a mass, which extends into the adjacent liver.
You may both be right. Yes. So this is a ruptured gallbladder. I actually literally today had a similar case where the gallbladder ruptured like this into the liver. But in this particular case, I like that you're also kind of like the pancreatitis thing. Like we should also always look like what caused this massive rupture. So we thought, first of all, that the fundus looked a little funky, not sure what's going on here. And then another interesting thing is that like there's some biliary dilation. And then they kind of like just disappear. There's not really clear like what is causing the bile ducts all in here to get obstructed. And then also like the portal vein is like a little narrowed as it goes through here. And even the right portal vein is narrowed. There's a lot of loss of fat planes here, right?
Yes.
Okay. So, and then there's a lymph node here. And we ended up getting an MRI. I'm going to show you the MRI, but in retrospect, there was some other clues on the CT and they're over here. So there was that nodule.
One more.
Yeah. So there was peritoneal disease already. So this is basically gallbladder cancer until proven otherwise, right?
There's one around the right kidney also.
That thing?
Yeah.
Okay. Yes. So yes, a lot of suspicious findings here. So, but this could be satisfaction of search. We're so focused on this ruptured gallbladder, you could miss all those signs. So we got the MR and basically, we see the ruptured gallbladder, but again, we see these bile ducts that are just kind of like disappearing in this area here and then like right here, there's all this kind of like evil gray stuff going on in the hilum. So they ended up doing an ERCP with brushings and it came back, gallbladder cancer, basically. They call it adenocarcinoma pancreatico-biliary primary. So they never, just on a brushing, they're not going to be able to get it. But basically we thought it was gallbladder cancer. And then I think that the T2s are actually the best place. This haste is a really good place to look for those peritoneal deposits because you'll see those little evil gray nodules like this. I know people sometimes say DWI. I'll show you the DWI here. I found it to be not as helpful because there's just like lots of bowel content. Like, these are the nodules, but there's just so much, bowel stuff that's lighting up as well that I don't feel like it's as clear. What do you guys think?
Yeah, I agree. The non-fat suppressed T2s are very good anatomically. And then we can correlate that with the DWI.
Yep. Yeah.
no.
I love this even for looking at the colon, like looking for a colon cancer and stuff. I really like this, the T2 haste.
Yeah, agree. So I guess this is a very typical and Aunt Minnie kind of a case.
Is it like the condyloma kind of?
A giant condyloma, Bushkill-Levinston tumor.
Wait, what kind of tumor?
It's the eponym given to it, Buschke-Lowenstein.
Oh, I've never heard that. And sometimes these are seen more commonly in patients, sometimes like with HIV, they can also get a concomitant squamous cell carcinoma. They're really difficult to treat.
That is correct. So MR is done to see
There's
if
huge
this,
lymph nodes in the inguinal
yes,
region.
that is correct. And MR is done, one, to see if there is sphincter involvement or not. And the sphincter here was involved. Also, if we see there is involvement of the penile shaft as well, all this irregularity. These are all condylomas. And yes, it was rightly pointed out, there were huge lymph nodes which were abnormal. And this giant mass.
So was there, oh, okay. Was there SEC in them?
There was a very good subtype of squamous cell component with this.
So Yashant, just to clarify, is it a form of squamous cell carcinoma arising from the skin, or squamous can develop within it?
Squamous can develop within this. This is just the most giant form of
Condyloma.
genital warts, yeah, condyloma.
Got it. Thank you.
Okay, I'm gonna ask a dumb question, but how can you tell the difference between a condyloma and hidradenitis suppurativa?
That hidradenitis occurs in the axilla.
Okay, sometimes it's in the
In the groin as well. You
yeah.
have that. So I think the etiologies are separate, and hidradenitis includes diffuse skin thickening because it's folliculitis recurrent, whereas condyloma is a growth by itself. Is it?
Got
You know,
it.
it doesn't arise from the follicle, hair follicle.
For hidradenitis, the diagnosis is clinical. Agreed, now they are coming up with radiological things. They are doing skin ultrasound. But by and large, the diagnosis is more clinical. And I mean, yes, for warts also, the diagnosis can be clinical, but I don't think we do imaging on a routine basis for hidradenitis suppurativa.
We've done plenty of them, and like for example, sometimes they're looking for like focal fluid collections associated with it, or involvement of the anal sphincter, extent of disease, etc. So I've definitely seen plenty of MRIs with hidradenitis suppurativa, but because they can see the skin involvement, but they sometimes want to know how deep and how extensive it is as well. So I have seen that on imaging too.
So maybe let me read and maybe I'll get back to you the next time because sorry, my understanding and my knowledge in that is slightly limited.
No worries. Thank you for showing that case.
I revisited this case because I was having a teaching session with our trainees, and I wanted to represent this case here. It's just a really classic. Yeah, exactly. So again, this is an oldie but a goodie. So this is the CNM anemone, and this was serous surface papillary borderline tumor. And you get those like projections, finger-like projections. Here they are again. So here is that stalk, and then here's the projection coming out of that stalk, which are classic findings for this entity. And it's interesting because it's not invading inward. It's just that growth pattern that's characteristic. Here's a really great AJR paper where we see similar imaging pattern of that papillary projecting growth that we see typical of this entity, borderline serous surface papillary tumor. And it's the malignancy is kind of unknown, so that's why they call it borderline. So it's neither fully benign nor malignant.
Beautiful. The stalk, what was that arising from? Like it's basically like exophytic off of your ovary?
Yeah, so it's coming from the ovarian surface,
Got it, got it.
and it has that branching look like a cauliflower. Other things that I would be notable in younger women, it has a very good prognosis. And then they can do fertility sparing surgery because it's relatively good prognosis. And as a CA 125 may be mildly elevated. And then ultrasound findings can show sometimes normal size ovary encased by tumor deposits with papillary architecture.
Nice. I'm glad you brought it back because I forgot about it.
And that's what I've noticed. I watch our recordings and then I'm like, oh, wow, I forgot to look completely. I mean, it's always great to just get a refresher to like put it in my long-term memory because I see it and I'm like, oh, what a fantastic case, but it doesn't stick.
Yeah, we have to keep watching our own videos too.
I think there is a cookie jar case on the same, and they talk about the sea anemone sign as well.
Yes, there is a cookie jar case. I can pull it up while Aarti's presenting her case if there's time.
Yeah, sure. What do you guys think?
Carcinoid?
Good thought. So there is like some kind of spiculated central mesenteric mass with calcifications. It's actually also like doing something to the SMV. You can see the spot, like the location of it. This is a non-con exam, so not helpful. But there's also this like, thickening and edema of the mesentery and of the bowel. And so there, we thought that could be due to venous engorgement from the SMV being taken out, maybe some degree of ischemia.
A progressed form of mesenteric, sclerosing mesenteric.
Good. That's the
Like
other major thing, right? So, and
Yeah.
all of these calcifications. And so how can you differentiate?
Dotatate?
Yes, exactly. So here's my dotatate scan. So before dotatate, sometimes we even biopsy these. This would have been really hard to biopsy because it was associated with all these bowel loops. But you can see that it's essentially like the soft tissue part of the mass is not dotatate avid. And therefore, this is highly unlikely to be a routine neuroendocrine tumor. We still haven't proven, but basically we have the presumptive diagnosis of sclerosing mesenteritis here. So this dotatate exam was very helpful. And one more thing. I just want to show. So sclerosing mesenteritis, it can be associated with some malignancies, like such as lymphoma and other kinds of malignancies, but that is usually rare. And just wanted to show you one thing. Most of the time, it's supportive treatment, but sometimes they will use steroids or some types of chemotherapy to treat it. And then if it's causing a bowel obstruction, they sometimes have to go resect it. So.
That was referenced. This is the cookie jar case that was referenced earlier. So this is from 2021 issue and showing the sea anemone sign, which is right here. So it's along the surface of the ovary and it grows through the stalk and kind of like this cauliflower look, which is what we typically see with this entity.
The picture says calcifications around it. Is it so it gets like these little popcorny calcifications around it? Is that what?
That's a great question. I'm not sure. I know we do see calcifications with kind of more indolent type variants of these borderline tumors. So maybe, but I don't think it's necessarily I don't know what percentage have calcifications.
Yeah, and then
But-
this example, like in the cookie jar and in your case, we don't have a CT, so it's hard to say.
Yeah.
Cool, it's beautiful.
Yeah, it's great.